Big difference in mental health is when you do a ward round, you're probably not going to see every patient and you're not going to walk around the ward. You'll sit in one room and they'll talk about the patients. And some of the wards, that might mean the patient, sometimes some of the patients will come in and talk as well to the team, but otherwise it's more a multidisciplinary team meeting is what they mean by ward round. So the biggest things are, I guess, there's handover every morning where the nurses will give a progress update on every patient. So anything that happened overnight that you missed, any new patients coming in, what's the background. It's always a good idea to read up on your new patients. So reading through the A1 or the recent, community mental health notes, find out who they are, and, who you can contact.
The teams work very differently because of the nature of the illness, the time it takes the medications to act. Not every patient gets reviewed every day. So that is kind of a change from your usual medical surgical jobs where obviously you're round, you see all the patients, and then you do your job sort of thing.
But probably the biggest differences are in psychiatry, there's much more focus on the multidisciplinary team. So you will have to work collaboratively if you want the client to get better.
One good thing that I really like about working in psychiatry is the MDT. The fact that you're working intimately with a large group of people, social workers, OTs, nurses, peer workers, and it's really good because everyone has their sort of area of expertise that they can really sort of help out with. And having that support, having that wide variety of people that's all looking after a patient can really not only help the patient and be in their best interest because they're getting expert opinions from a lot of different specialties, but also makes your life a lot easier. So in terms of getting collateral, for example, a lot of the time nursing staff can be quite obliging in doing that. Social workers can be a great assistance with liaising with family and even liaising with other health agencies. They can really be a lot of help to decrease the amount of workload that you have on a day-to-day basis.
We start late, we usually start about 8:30, which is good. And we usually start slow, like you have handover meetings and all that stuff, and after that you start seeing patients.
One of the big differences that you'll notice in your psychiatry term is the nature of the ward. And there can often be some dynamics on a ward in mental health that you probably don't feel on the medical or surgical ward. So my advice, I guess, would be to know that it's very multidisciplinary focused. So you've got the medical team, but you've got mental health nurses and nurse unit managers, and you've got allied health. And more than any other unit or ward, you'll see them working together collaboratively. And you'll really see it in motion, and it's a real privilege to see how it all fits together to work for the benefit of the patient.
Initially, I would say don't see patients by yourself. Get a nurse with you, get another doctor with you. Don't see them by yourself for your own safety. Then secondly, if a patient asks you for leave, asks you for anything, please say, I'll discuss with my team and get you back initially if you don't feel comfortable. And I think that's what most people do as well. Even when they're consultants, they always say, we'll discuss with the team and we'll get back to you.
Unlike medicine where you just write in the notes, these 77 people to deal with the patient and the nurses coordinate that, it's always helpful to go and actually talk to the different specialties about your patient. So go to the psychologist and ask what you want, or ring the psychologist, or go to the social workers and ask what you want. And you'll find that the people you work closest with are probably the social workers because they do a lot of the things and they're very helpful. So take really good care of your social workers, but don't be afraid to ask the rest of the team for help because it is a much more closely networked multidisciplinary team than you have anywhere else.
Often patients will present with a multitude of stressors, and it could be related to housing, income, substances, all kinds of things. So you need to work with nurses, occupational therapists, and social workers. And there needs to be clear communication. Sometimes you can fall into the trap of saying, social work to try and fix this, or OT to try and fix this. But they're all parts of a greater whole.
The initial assessments can be quite long for patients, and I think one thing that people outside psychiatry don't realize as to how emotionally draining it can be sitting and talking to someone for hours and hours and hours. It's not a lot of physical work, it's not a lot of running around from here to there, organizing scans, organizing appointments. Usually that's not so common, but it's very emotionally taxing, and it can drain you.
It's very important that you debrief with your colleagues, so with your other JMOs, and as well with your registrar and your supervising psychiatrist, and also in the HNET they've got a good debrief scheme every week, so I would definitely encourage that. And there's always time to reflect in psychiatry, so if you're feeling particularly anxious about something, just think, okay, what is it that's going on at the moment? Okay, I'm feeling angry that that's been said about that person, or that this is what's happening with that patient. So I guess always be mindful of what it is that you're thinking and feeling, which can be hard, and it can be fairly new, because I guess on the medical and surgical wards it's just about, yep, they need bloods, they need an x-ray, they need all of these things, and once they're done, then there's not much more, I guess, beyond the physical. But here you're being asked to, I guess, build interpersonal relationships, not only with the patients but with the staff.
Take care of yourself. I think it's important to just relax, have good. What do you say? I'm not sure. It can get quite emotionally draining, so be mindful of that. And just, I suppose, you could do is just discuss things with your colleagues, with your registrar. You can just discuss, oh my God, I don't know why I just have this dislike towards that patient. And that kind of is a clinical input as well as to how you feel about the patient. It's got clinical value in psychiatry, and it's good to discuss those sort of things.
It's not all great though. When working in a team environment, it can sometimes lead to conflict. But as long as there's sort of open communication and everyone sort of realizes their role and their responsibilities, I found that it actually works really, really well.
It can be difficult to manage the dynamic on a psychiatry ward. There can be lots of differing opinions, lots of emotions, and certainly there can be the emotions that patients bring up in staff, and how you approach that.
Mental health wards are locked wards. Most of them are locked wards. So if someone's asking you to let them out, please don't. Just refer back to the nurse.
A lot of JMOs, I think, find it very different working in psychiatry compared to some of the other specialties, just in the way that it's run. So one thing that I noticed when I sort of came into it was you can't necessarily just have a job list for every patient and expect to finish it by the end of the day. It doesn't really work that way. 9 times out of 10, a lot of the stuff just doesn't get done for a long time. Sometimes the whole admission, nothing really happens.
I think as a JMO, I think it's important that people know that, decisions like whether someone can go out on leave or whether someone can be discharged, they're not your decision. And it's always good to just defer it back to the team, and make sure that you know that, look, I'm new here, I'm not going to go and make a family meeting and set up discharge planning. That's absolutely not what you need to do. I think it's important to validate people's concerns. You'll often find that people will come to you and say, oh, why is this patient still in hospital? And it can be really quite confronting, and people can be quite abrasive and hostile sometimes. And I think it's important to say, look, I completely understand. I hear that you're really really feel for this patient and you think that they should go home, look, it's not my decision, it's not my call, we can definitely talk about it with the team and I'll bring it up with them. Unfortunately, I can't make that decision, but I absolutely hear what you're saying.
Duress alarms is something that is used widely in mental health units. Every mental health unit, and technically, as per protocol, I think you're not supposed to be on the floor without a duress alarm. So once you start your posting or your term there, so the ward num or the ward admin staff will show you around the duress alarm, will show you how to test it, where to sign out for it, and you've got to carry it around. So my advice would be, yes, please take it, please carry it along. A lot of people after some time don't do it because the alarm tends to go off and all that stuff. I'm going to tell you to take your alarm at all times and keep it with you at all times.
The only other general tip I would have is every review with a psychiatrist, go in with extra progress notes. They will always go over one page. They are incapable of not going over a page. So always having extra progress notes, always having a little bit of an idea about the patient, trying getting GP summaries are always helpful because there's a whole bunch of information they won't know is important or won't remember or won't be able to give you, and have a checklist in your mind of things that you think need to be done for every patient. So, legal status, physical health. So things like, did they get a physical in ED or PEC? Do they get, how often do you want their physical obs to be taken? Do they need blood tests or investigations? Do they need an ECG? Are they on antipsychotics? Do we need to check the QTC? And then going through the process of, do they have any leave? What obs level do you want them on the ward? Whether you need any allied health input, so social work, occupational therapy, psychology, do you want to refer them anywhere? And what collateral you might need, whether you need collateral from the GP or the family. And so when you're making a plan, have a checklist that you work off for every patient and make sure you're asking the boss those questions because they will forget. And you can always ask your consultant always ask them impression and plan. And then if they've missed things on the plan, you can ask them if those are necessary and they'll tell you if they are or they aren't.
And take your ADOs and take your time off.
It's a different ball game, but it can be really fantastic and rewarding. I mean, there are hard days, but there are definitely more good days that outweigh them.